Welcome to OAC Health Talks. I'm Joe Naglowski, President and CEO of the Obesity Action Coalition, and we are excited for you to join us for this educational series that dives deeper into specific health topics that we know are important to you and the OAC community. Health Talks are designed to empower you while providing straightforward, practical answers and insight from trusted experts. So let's dive into today's topic.
Hi, I'm Dr. Nina Crowley, and I'm excited to be here with Dr. Angela Fitch to talk to you today all about body composition. So our agenda is going to be to first talk a little bit about the assessment of obesity, to talk about body composition, and really to hone in on what the changes you might experience during weight loss may be, and finally find out how to find out your body composition.
Thanks, Nina. You'll see this consensus on obesity as a disease. Our Obesity Medicine Association and the Obesity Action Coalition and the Obesity Society, we've all come together, many other associations and societies too, all came together to write this consensus statement because we felt as though it was important to acknowledge that obesity is a highly prevalent chronic disease that's characterized by excess fat accumulation or distribution that presents a risk to health and requires lifelong care. The importance here is the body mass index is used to screen for obesity, but it does not displace clinical judgment. BMI was never created as a certain measure that people should get to. It was created as an epidemiological tool to assess risk as it relates to disease related to body weight. But it doesn't measure body fat. And in fact, if you notice that definition, it talks about excessive fat accumulation that presents a risk to health. So that's what we're talking about today about body composition, because really what we should be concerned about is our fat and how that relates to our health, not just the number on the scale. These are changing times, and now it's really time for a change. Understanding the disease of obesity. Obesity is a multifactorial disease that requires a multifaceted, patient-centered, individual approach that one size does not fit all. The American Medical Association has a new policy recognizing issues and limited value of body mass index. BMI is for screening, but not for sole diagnosis and treatment for an individual. It was never based that way. It was based to look at population data and not to look at an individual or an individual's treatment goals. The American Medical Association has suggested alternatives such as measuring waist circumference, body composition, and visceral fat, which is the fat around our belly that tends to lead to more health conditions. Assessment and language really matters. When we assess for the presence of obesity, adiposopathy, and fat mass disease, we're initially looking at BMI as a screening tool. But really what we're looking at further here is percent body fat. Adiposopathy is just a fancy word for how our body fat can make us sick. So body fat releases chemicals and cytokines that make us unwell in certain circumstances. This can be genetic, it's related to our genes, our environment, everything together. It's not a one size or one condition type of issue. There's also fat mass disease, which is where just the mass of our extra weight leads to issues, say, with our knees or our back, or other issues like sleep apnea. So it's important that we look at all of these features, not just how much we weigh and what our BMI is, but what is our percent body fat? You'll see that normal for females is less than 32%, and for males less than 25%, right? And so again, that's kind of the goal we're trying to achieve, is those goals versus just looking at a number on the scale. And where our adipose tissue or our fat mass location is matters to us, right? If you look at the picture on the left-hand side of the screen, you'll see that the blue represents subcutaneous adipose tissue, which is the body fat that's just under our skin. And then you have the visceral adipose tissue, which is in closer to our organs. So this is a cross-section of the human body, as a CT scan of the human body, looking at the cross-section across our body, right? And you'll see that yellow fat is that visceral adipose tissue around our organs. And that's what can increase our risk of diseases such as heart disease, diabetes, or other complications, fatty liver disease, etc. So we're really trying to get rid of some of those health conditions and focus on getting rid of some of that body fat. Certainly subcutaneous fat, like I said, can have a risk for sleep apnea and also can just be uncomfortable or maybe, make it a challenge for us to fit into an airline seat or use a seatbelt extender, etc. But really getting rid of our visceral fat is also what plays a significant role as it relates to improving our health and our health outcomes.
And Angela, I think the other point I always think about when I look at this slide is the image here on the right. So these are cut-throughs of whole body MRI scans of folks, and they all have a BMI of 24. But if you look at the top left, that's someone who has a lot more lean tissue than the bottom right, someone who has a lot more of visceral adipose tissue and subcutaneous. So, it's not something we look at every day, but this is something that when you look at it this way, you can really see how just the weight on the scale would really mask the real difference in health risk that someone on the bottom right would have compared to someone on that top left.
And clearly I'm not a radiologist because I said it was a CT scan, but since it's an MRI, we will stand corrected because thank goodness I'm not a radiologist.
So, Angela, I pulled this actually from the Obesity Medicine Association's newest obesity algorithm, which I think is a really fantastic resource for healthcare providers. I really thought they did a good job outlining the different measures or measurements that we can do to assess someone's body composition. And they go through the method, they share the accuracy, how expensive it might be, as well as some limitations. So for healthcare providers, we have to think about how are we going to be able to offer body composition technology to someone. We're saying this is an important measure. The AMA is supporting. We need different measures to tell people how they're doing, to assess their risk. It's not just about BMI, but we really need to think next, well, how are they going to do that? And so if you look here, there's some methods like underwater weighing. I don't know anybody who's doing that in clinical practice, but some of these are measures that we use almost as gold standards or reference measures to do the body composition test. And then we use other measures like bioimpedance or air displacement, like the BOD-POD. We compare those results to these gold standard measures, and when we get something like 97 or 90% accuracy, we feel confident enough that these are the technologies we can use in a clinic setting that estimate the body composition with enough accuracy. So we're going to go through the three that the obesity medicine algorithm outlines, which are the DEXA, the air displacement, also known as the BOD-POD, and then bioelectric impedance. So I pulled an image of those here for you. The first on the left, you may be familiar with the DEXA scan. This is often referred to as a bone density test. This is a way that we can estimate body composition in 3 compartments. So we can look at your body fat, we can look at your bone density, and we can look at your lean tissue. That's everything else. The whole body, I can't say that word, the BOD-POD. This is a measure that looks at air displacement when you put someone in this little spaceship-looking device. And this, I don't see this as used as much in clinical practice. There's a lot of factors we'll talk about on the next slide. Patient consideration. So this one you have to get down into a bathing suit and put a swim cap on, and that's not feasible in most people's practices, and I know I would not want to do that in a doctor's office. They also require trained staff, and so the bioelectric impedance analysis, which you see a lot more about because it's a lot more feasible, that is a measure where you're looking at the body composition from a fat mass and fat-free mass, but you're comparing it to those gold standard measures. So the 4-compartment model for fat mass, it's 4 different measures they do on a big, long research day to make sure they get all of the, data there. They compare that to bioimpedance, and then they also do the muscle mass, and that's done through MRI, which is the gold standard for muscle mass. So talk about this a little bit more. This is where we have experience in the clinic setting, and we'll even talk a little bit about some of the home devices that people can have, while they're not maybe as accurate or as precise as the measurements that we're talking about here. They do offer some value for consistency in measurement for some folks. So to me, the patient is always first on my mind when I think about how are we going to apply these body composition measures in real life. So first, of course, we have to think about size and weight limits. The different devices have very different weight limits. And so even a DEXA scan, which can be commonly used for, primary care might refer you to get a bone density test. And Angela, you might even know more about this than I do, but they do have limits for how big someone can be in the device. And they end up sometimes estimating one side versus the other and extrapolating that number or estimating the rest of the body from that. I've seen size limits from 250 to 350 pounds. They do have some at higher levels, but those are pretty hard to come by and not very available to folks. The other piece here is the comfortability on or in a device. So if you remember looking at any device you have to go into, we have to think about, do people feel comfortable doing that? Are they going to fit in that? There's a lot of, nervousness around size and devices that we have to be cognizant of. We also want to make sure that we're not continually putting someone on a device where they're going to exceed the weight limit. That can be embarrassing and it can be frustrating, and we're not getting the data that we need. So we do want to look for a higher weight limit when we're looking for equipment that we can offer to estimate someone's body composition. The amount of time, of course, is important. As doctors like Angela know, it's important not to have something that takes 30 minutes to slow down the flow in your clinic. I also think that's important not to have something that you are going to have to go off-site for and have a referral and send the results back, and where did they go? Are they stuck in the fax? Are they in, there's a lot of administrative components that we need to think about. In my previous role as a bariatric coordinator, that was all I thought about, was how are we going to make the flow of all of this happen? And so that was really important. And then to the patient, you want to be careful that you're not asking them to take a whole lot of time to find out something that they're hoping that can help their care plan. Clothing required or not. So again, I mentioned that with the, having to get down to a bathing suit or a swim cap. I think that's unrealistic for most people. The bioimpedance devices usually are just take your shoes off and socks off so that you can pass that low dose electrical current through the feet and that goes out through the hands. Validation equations, maybe that's not a practical consideration, but that does have some differences between the devices that you'll see, whether or not they're validated to an MRI or to DEXA or to the 4-compartment model. Use of trained technicians, that's a big one, because I know with an X-ray tech, that's a whole nother level. I remember we used to have the gastric band. We had a C-arm that we had to bring down from radiology to fill a gastric band, and getting that technician around, that it wasn't easy, and there was a lot to go into that. So we have to think for DEXA if that's something that you have available, and or is it something you can just get on the device and anybody in the clinic can punch in the numbers and give you your results. And then understanding results. I add that because that's my role in my current job, is teaching providers how to teach their patients about results. And it's a lot more than just, here's the number, the old, here's the BMI on the chart. We're really hoping your doctors and your healthcare providers are not doing that. We're hoping that they take the time to go into understanding these results with you and helping you come up with reasonable action plans from the data that you're learning from these body composition measures. So understanding the results, there's so many different measures out there. There's variety in the companies and what they're offering. So I wanted to kind of boil that down into a few areas that we're going to talk about. So muscle mass and fat mass are the two primary areas that folks want to know when we're looking deeper than weight at your body composition. So with muscle mass, you first look at the fat mass and the fat-free mass. The fat-free mass is everything in the body other than your fat mass, and that can tell you, there's things that can tell you about your health risk, that can tell you about, how much muscle mass you're keeping. It's kind of a proxy for that, but we can get even deeper than just your fat-free mass. We can look at the lean soft tissue or the lean body mass, and that's what a DEXA would tell you. That does include things like connective tissue and skin and fluid and hydration, so it's still not exactly what we're looking for, but we also can narrow down to the skeletal muscle mass, and that's really what we're wanting to protect, that skeletal muscle mass. segmental would be if your bioimpedance device would be able to show you how much muscle you have in each arm and each leg. And for some people, it's important to know, different parts of the body if you're wanting to train differently, or if you have an imbalance, or for any other kind of medical reason. So there's a few different ways we can talk about your muscle. That's becoming very important. Angela's going to talk about that in a minute, as we're talking about significant weight loss and how it's affecting muscle. So we'll come back to that. But as she talked about adiposopathy and your adipose tissue, we're wanting to look at how much of your body weight is made up of adipose tissue. And not just how much, but where is that located? So for bioimpedance technology, you can add something like your waist circumference. So measuring the distance around your waist can actually add data to these algorithms that estimate your visceral adipose tissue. And that's the fat around your organs. And that's much more closely related to health risk and health status than simply just your weight on the scale. And I know for me, Angela, you may have thoughts too. I've been really interested to see folks who may have a high BMI, they may even have a high body fat percentage, but when we look at where that's located, it may not be around their waist, it might not be around their organs. And for that person, seeing that visceral adipose tissue at a lower level is quite encouraging when we're actually talking about connecting health and these parameters. We're not talking about weight. And so this is really, to me, one of the most exciting parameters that we can talk to patients about, because it really does make that connection for them. And when they're losing weight from that area, we can see the connection to their long-term health. So my question that I'm posing to you, Angela, to answer, and is what happens to body composition during obesity care treatments? And I pulled this picture because it's your hand and your muscle mass. So I thought you could address that for us here.
That's great, Nina. And yes, I do think, that when people can see these changes happening, right? Even when, for some patients, they will have gained 5 pounds of muscle mass and lost 5 pounds of fat mass, and their weight doesn't change, but yet that's so much better for them, right? From a health perspective, to have that increase in muscle and that decrease in fat. And so that's why this is so important, to look at these factors, whether you're doing it at home on a home scale, as you mentioned, or more importantly, when we do it repeatedly in the office, at least we're getting a very accurate look at that so we can counsel patients better. Significant weight loss typically results in the loss of both fat and muscle mass. The most important thing to remember, and you're hearing a lot in the news right now, right, about how, potentially using medication to assist with weight management, how people are losing muscle mass. But that's been for a long time. People have lost muscle mass when they've lost weight, because that's what happens. And in fact, a lot of people that carry extra weight or live in a larger body actually have more muscle mass, because if you can imagine, when you used to weigh 40 pounds heavier, you were carrying around 40 pounds every day, which is not an insignificant amount, to carry around, right? This is like a 40-pound backpack is really hard to put on and carry around all day. Excessive loss of muscle is rare, but it's important to monitor so you can adjust treatment if needed. Or if you are a person that potentially has a lower muscle mass to start with, we sometimes, will guide the treatment, or we should guide the treatment differently for that patient, because the fact of the matter is our ultimate goal as humans is to get up out of the chair when we're 90 years old by ourselves, right? To be strong enough to be able to have enough muscle mass to still do our activities of daily living, as we live a higher quality life over time. We lose muscle mass every year as we get probably over the age of 30 or 40 even. So, every year over 40 in particular, we start losing muscle mass. And if you don't use it, you lose it type of thing, right? That's the old adage. And so really, being mindful of that and following this can be helpful so that you can build back that muscle mass as needed. When you lose muscle mass, it reduces your resting metabolic rate. So it makes it harder to lose weight the more muscle that you lose, because muscle burns more calories than fat. It's important to note that muscle, there's a lot of people that say that muscle weighs more than fat, and it actually doesn't, meaning a pound of muscle is the same as a pound of fat. It weighs the same, the weight is the same, but certainly a pound of muscle takes up a lot less space than a pound of fat does. And so again, it's more of I tell patients all the time, our goal in treatment should be to be leaner, not lighter, right? We don't want to weigh less. We want to be leaner and more compact, so to speak, and be stronger. So when we look at both fat mass and lean mass loss over time with various different interventions, these are dietary interventions alone. So these are without any type of medication assistance or surgery. But when we lose weight over time, you can see in the blue is the fat mass and the gray is the lean mass. So it's pretty normal, essentially. You can see here that when we lose weight, that of anywhere from 20 to 30% of our weight loss is coming from our lean mass loss. It's coming from our muscle. It's coming from the fact that we also lose some fluid from that compartment too. So the thing is that it's coming from that lean mass, because when you lose weight, your body just doesn't pick from your fat mass, unfortunately. We wish it did, but bodies don't do that. And so again, that's why it's important to really sort of do some strength training while you're, some resistance exercise. Doesn't have to be with weights or anything, but some resistance exercise and consuming enough protein. And that's why we harp on those two things, during weight loss, because we know that's how we try to protect from losing too much of that lean mass loss. You'll notice in that high protein diet, it actually lost a little less of that lean mass, we think, because protein protects that lean mass from going away. This is data on surgical intervention. So people that had surgery, and you have the weight loss on the x-axis and the time on the y-axis. So 3 months, 6 months, 9 months, 12 months, 18 and 24 and so on. You can see that again, it's about that same ratio of about 70 to 80% of the weight loss coming from fat mass. That's the gray in this graph. And then the rest of it coming from fat-free mass, of which part of that is muscle mass. So again, it's normal to lose muscle mass when you lose weight, but we're trying to protect that as much as possible. Here is a slide of medical interventions. So this is a slide looking at semaglutide, which is currently one of our medications that we use for obesity treatment in the clinic. And you can see here where we have this person is starting out on the semaglutide with 43.4% total fat mass and ending up with 39.4% fat mass. So they lost that fat mass, and in this case actually gained some lean body mass. So again, the point is from a percentage standpoint. So the percentage is getting better, and that's what we want to try to change. We want that percentage to improve over time, and that's what we're trying to do, because we know that getting rid of that body fat is what improves health outcomes long term. It's the fat that's not good for us, not the fact that our weight is a number on the scale. So how to get body composition analysis. This is me, and you can see I'm very excited to be on my new body composition scale that we got in the office. So being able to do that for myself here, you can share in my excitement of getting the new device. Many obesity care providers have bioimpedance devices in their office. So this is a bioimpedance device. Many of us have that type of device, as Nina mentioned, because it is something that is easier to do in the clinic. It's under a minute of doing the procedure itself. It measures you very easily without, like Nina said, without getting undressed too much, just taking off your shoes and your socks. You can also find them at some gyms and wellness centers and fitness facilities like the YMCA or Crunch. They may have bioimpedance devices. So some gyms also have a very similar type of device. You can also be referred to get a DEXA scan, which is the same DEXA that would be used for bone density, but you have to ensure that they have body composition software attached to it. So while most DEXA scanners can do body composition if they have the right software, not all of the DEXA scanners that you find, like if you go to get your bone density done, you can't just ask to do your body composition too. So it just might not have that on there. Plus, it's not a covered benefit of your insurance, unfortunately. So because of that, typically when you go get a DEXA to look at body composition, there's a fee for that. That's an extra charge. Whereas when you're doing it here in the office, we typically include that as part of our care plan.
And I just wanted to end with, we're talking, of course, with the OAC, always about advocacy. And so I think this is an area where patients really do have a role in advocating for moving the outcome of choice away from just weight on the scale to something more meaningful, like body composition. So we do know, and hopefully you know, that providers do listen to their patients. I've seen that over the years, I promise. They're out there. And if not, the Obesity Action Coalition Obesity Provider Locator will help you find someone who can. We also know people these days especially want to be competitive in their market. So they need to be listening to their patients and what you're asking for. So if you have a provider who does not have this technology, who has not talked to you about this technology, please do use your voice to advocate for better outcomes and ask those questions and find out what the barriers may be. They may know someone in the area who has something and they can make a referral. There's some ways around, what they have exactly today, and hopefully we can start, moving the needle on having more providers with this type of technology. If you're undergoing a treatment with a goal of significant weight loss, as we know many of you do, we believe that you should know where the weight is coming from. So, just like we're asking and demanding better care with different treatment options, with more access to dietitians and behavioral health and exercise professionals, we would want to have better outcomes measurement. And then share your data and your standards of care and stories to support your requests. What I mean by that is, talk to your provider about your numbers and how it would be helpful to have more detailed information about where that weight is coming from. The standard of care, that's something that we all can do even as healthcare providers. We're moving towards, as you can see, from the different societies in the American Medical Association, we're moving towards better outcomes. And sometimes it feels like it takes a long time, but I know we talked recently about Advocacy on the Hill for obesity care, and we've been doing it for 10 or 11 years on one specific piece of legislation, and that feels like a really long time, but I do feel like there's more energy and support for this more than ever these days. So use that to support your requests. And your story is important. If you're someone who was able to see a change or was able to stay motivated, I think one of the most exciting parts of body composition analysis is the way that people can be motivated to do some resistance training, and they might not have before. They might have thought, hey, I don't want to get big and bulky with muscles, and so, I've just been walking or just been doing aerobic exercise. And when they see their muscle mass at a low level, they're, and see what happens as we age, I think that's really a nice motivator to do those things. And they're health behavior things that we may have known we wanted to do, but somehow seeing that data for you as an individual really helps put some energy behind that becoming one of your goals. And I don't know, Angela, do you have other thoughts on how patients, if one of my thoughts is when I talk about this to folks, I'll have patients tell me, well, this is great, I would love this, but my doctor's office doesn't have it. And I think a lot of times we sort of stop there like, oh yeah, that's unfortunate, we need to get them to get it. But are there other ways that people can advocate for this or get body comp analysis done in a different way?
I think they should ask, right? And really sort of, the more people talk about it, like you said, the more people are going to get it. There are some places opening up, at different areas that will offer it at gyms and such, so that you can, and you can pay a fee, typically to do that. We're trying to advocate to get this covered as part of insurance, as you know, too, because this is something we feel like is an important test that we should be doing that could be something that would be covered by insurance. Right now it's not, so it's typically can be an extra cost. And just to also add, you mentioned, home devices, right? Home devices are not as accurate as the devices we have in the office. So just know that it's not going to be matched up to what you're seeing in the office, but you can use it for trending. The biggest thing to remember about home devices is you get kind of what you pay for, meaning usually you have to pay a little bit more for something to be a little bit more accurate or a little bit, more precise. So usually, if you're getting something for really deep discount, it might not be quite as high quality as something that costs a little bit more. And the other key is to remember when you're doing bioimpedance, like the home scales that measure your body fat percentage, you cannot let your skin touch each other. And that's very challenging on the home devices because, our legs tend to touch each other in various spots. And especially when we're standing there, typically right after we get out of the shower or something, we don't have any clothes on. So making sure that you put something between your legs so that they don't touch, or somehow, make it so that your legs are apart and not touching is key to get a better accurate measurement at home. That's what I tell patients when they have when they might have a home scale because they can't get into the office to get checked.
I also always add the caveat for folks, again, with a 18-year history in bariatric surgery, I saw a lot of patients who became overly focused on the number on the scale. Part of why I do this is to advocate against that, and that can be quite detrimental to someone's quality of life. And so my only worry with a home scale is that when you have a lot of data and you're someone who sort of wants to gravitate to doing that frequently, I think people can over measure and then make silly or unfounded decisions like, oh, this is higher today, so I'm going to not eat what I just ate for that last meal because that has to be the reason that there's a difference. And I mean, really the whole point of all of this is giving you a better outcome metric to see the results of the efforts. And the efforts is all that hard work that you're putting into the daily choices that you're making. I think sometimes those frequent check-ins with weight or bioimpedance or body composition data can be counterproductive. And so, while we know individualized care and a patient-centered approach means everybody's got a different plan that's going to work for them, I do see that as a trend for people who have access to that too often.
I agree. And it's very important to recognize that, our body weight and changes in our weight fluctuates on a daily basis, even throughout the day. So, we can't really focus on a number too much, right? It's all about the ultimate long-term goal, which is improving our health and improving our quality of life.
Well, thank you, OAC, for having us talk about this important topic. And hopefully, if people need to reach us, we're linked to all of the OAC's channels.
The OAC has a variety of educational opportunities for you throughout the year, but one of the best places you can turn to for quality, unbiased education is our resource library. Simply visit obesityaction.org/library to check out our brochures, articles, guides, videos, and more health talks. Also be sure to subscribe to our YouTube channel to get notified about any future educational events. Thanks for joining us.